Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all on the second day of Oncology Updates 2022 and beyond. And with immense pleasure, I would like to invite Dr. Devesh Goyal, who is Senior Consultant Medical Oncologist, Fortis Hospital, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah. Thank you. And thanks to all my participants as well as my seniors and faculty. And today is yesterday the day is very good and very well discussed about this breast cancer. And today is the part B, means grade 2. And we will discuss on this GI cancers as well as GU cancers. In the GU cancers, the kidney as well as urothelial cancers and prostate cancer will discuss, and further the ovarian cancer will discuss. So today the topic of discussion under the GI cancers in this colorectal cancers as well as esophageus and stomach cancer we will discuss. So just about in this conference to update daily to daily routine, what are the changing, and mainly a basic purpose of the event today is to know our clinical scenario, what is our clinical scenario, clinical practice, and what is further guidelines and changing the scenario overall world. So further, I will invite for this session, I will start with this Dr. Deepak Kupakkal. He is consultant medical oncologist and care hospital Hyderabad. So he will deliver the talk on the topic of cabazitaxel in this prostate cancer. So I will invite Dr. Deepak for this talk.
Yeah. So
over to you, Dr. Deepak.
Yeah. Thank you, Dr. Devesh, sir. Thank you for this opportunity, and I would like to thank the organizers, including Dr. Devesh, for giving me this opportunity to talk about role of cabazitaxel in prostate cancer. As we all know, at least 5 years back, there were only 5 options on how we used to treat prostate cancer: 2 hormonal agents and 2 chemotherapeutic agents. And of these chemotherapeutic agents, cabazitaxel stood the test of time. And how do we sequence these agents into practice is what I will be discussing over the next 15 minutes. So the topic is role of cabazitaxel in prostate cancer. And as we all know, there is very limited role of this agent in early stage and also hormone sensitive metastatic prostate cancer. We limit this agent predominantly to our CRPC metastatic patients only. Now, while we make these therapeutic decisions for metastatic CRPC patients, there are various factors we take into consideration, like how symptomatic the patient is it a biochemical relapse or overt radiographic progression, an entity which is relatively less common in our practice in view of widespread availability of PSMA PET CTs. We rarely encounter scenarios where patients progress only on biochemical features on PSA alone and do not have evident radiographic progression on CT scans and bone scans. And we also, the factors for deciding treatments include what prior therapies a patient received and initial ADT response, which is now a little obsolete because we hardly put patients on ADT alone, metastatic hormone sensitive prostate cancer patients on ADT alone. We usually either add a single agent or double agent in these group of patients. And we also know that the currently available 2 hormonal group of agents, that is abiraterone estates and the androgen receptor antagonists like enzalutamide, darolutamide, they have a crossover in the resistance mechanisms, and there is these individual agents when sequenced, the efficacy is lesser compared to individual activity in first line. So just briefly on where agents are, how agents have been evolving into this practice of metastatic prostate cancer. We are aware that till 2010 we have predominantly given, sorry for that. Yeah. So till 2010, we were limited with only docetaxel, but after 2010, we had agents like abiraterone, enzalutamide being available widely into practice. And as early as 2021, the recent years, there is a newer agent called lutetium, which has received widespread acceptance, and lutetium therapy has now got a US FDA approval. Newer agents like alpha emitters like actinium PSMA therapies are coming up actively in cities, wherein patients who've been refractory to lutetium therapies, we are using actinium in a few patients and seeing excellent responses. Now coming to optimal sequencing of the agents which we routinely use in practice, a point of how do we sequence abiraterone and enzalutamide? Because for docetaxel and cabazitaxel, the data is pretty clear following a phase 3 card study and other studies. How do we sequence dosi and cabazitaxel is very clear, but how do we sequence abiraterone and enzalutamide is a very nice article. It's a phase 2 study which was published in the Lancet in 2019 by Calaf et al., wherein they seen a crossover from alternative agents. If patients who were initially on abiraterone, later switched on to enzalutamide at progression, or patients initially on enzalutamide, then switched off to abiraterone, it was seen that predominantly in these group of patients, if abiraterone is given first, at least 1/3 of the patients respond to enzalutamide at a later point of time. But if the initial patients were exposed to enzalutamide, the response to abiraterone is very minimal. So in sequencing therapies, particularly when we're introducing these agents into hormone-sensitive metastatic prostate cancer, that is the de novo hormone-sensitive metastatic prostate cancer patients, it is better to put these patients on abiraterone rather than enzalutamide, because post-progression on abiraterone, we can still introduce enzalutamide into the treatment paradigm of these patients. But coming to chemotherapy, things are very clear with chemotherapies, where in this group, that one of the earliest chemotherapy which got approval was docetaxel. Prior to docetaxel, mitoxantrone was used, but both following the SWOG 9916 and TAX327, the 3-weekly docetaxel regimen stood the test of time and is the current standard of care in first-line chemotherapeutic agent in metastatic CRPC and hormone-sensitive prostate cancer. Now, in the second line, cabazitaxel, this was discussed in the TROPIC studies. Cabazitaxel showed a significant overall survival benefit when compared to mitoxantrone, and a little 3-month improvement in the median PFS, and the 30% risk reduction of death was seen in the TROPIC study. Now, coming to detail, cabazitaxel is a semisynthetic taxoid compound demonstrating activity against taxane-resistant diseases. As we all know, neutropenia is the primary dose-limiting toxicity, and in the TROPIC study, it was shown that an overall survival advantage was seen with cabazitaxel in the second line. As discussed, so these are the agents. Now, radiopharmaceutical agents, we have lutetium, which has got approval last year, and we are also actively looking out after actinium therapy, which is also an alpha emitter. New kid on the block is olaparib and rucaparib in BRCA positive prostate cancers, which count around 10 to 11% of all prostate cancers. So this is a study which has cleared the air on how to sequence cabazitaxel. So patients post progression on docetaxel and one line of hormonal therapy, how would it better be sequenced? Like we told in the phase 2 study by Calaf et al., it was seen that sequencing abiraterone followed by enzalutamide is a better strategy. But is it better to introduce cabazitaxel in this space, or should we use hormonal therapy? Was discussed very clearly in the study. In this study, the dose of cabazitaxel is 25 milligram per meter square and given in combination with prednisolone and growth factors, was compared with enzalutamide and abiraterone. Patients received docetaxel at least more than or equal to 3 cycles of docetaxel was mandated, and one hormonal therapy was allowed. The primary endpoint was image-based PFS, and it was seen in this study a significant PFS benefit was seen, 8 months versus 3.7 months compared to androgen hormonal therapies. Cabazitaxel fared better. Even the overall survival advantage was seen, nearly 2.5 month advantage was seen in the overall survival, following which it is better to sequence cabazitaxel upfront than using androgen receptor inhibitors in these group of patients. Now, is it better to even bring cabazitaxel upfront and replace docetaxel? So this was addressed in the Pastana study, where they've used 2 doses of cabazitaxel, that is 20 milligram per meter square, along with 25 milligram per meter square. This was in metastatic CRPC patients with no prior chemotherapy. The primary endpoint was OS. The study was well balanced across all arms, and patients were allowed to use enzalutamide or abiraterone assisted before this agents. And it was seen consistently that though a numerically superior higher response rates were seen with 25 milligram per meter square cabazitaxel, there were higher toxicities noted, but no advantage in PFS. That was a consistently similar PFS was seen across all groups, and also consistently similar OS was seen in all groups. So it is better to sequence docetaxel followed by cabazitaxel consistent in view of the significant overall survival seen with cabazitaxel over second line hormonal and therapeutic agents. But in first line, docetaxel or cabazitaxel, it's more or less equivalent PFS and OS. But we prefer to use docetaxel in view of lesser side effects seen with docetaxel, and significantly higher febrile neutropenia was seen in patients who received cabazitaxel at a dose of 25 milligram per meter square. So the study failed to show any superiority of either cabazitaxel or docetaxel. PFS and OS were actually comparable, and there was a different toxicity profiles with cabazitaxel versus docetaxel. A little more peripheral neuropathy and a more allergic reaction was seen with docetaxel, but more febrile neutropenia was seen with the cabazitaxel arm. So intensification of systemic treatment is the new standard of care in metastatic hormone-sensitive prostate cancer, where triplet regimens have shown better outcomes. The PEACE study and the other studies have significantly shown nearly a 2.5-year survival improvement by using a triplet regimen. Next generation androgen receptor signal inhibitors improve metastatic free survival and overall survival in CRPC, but it's better to sequence these agents after abiraterone acetate. Cabazitaxel improves PFS and OS in patients with CRPC and disease progression after novel hormonal therapeutic agents and docetaxel. With the advent of PARP inhibitors, we have further challenges in sequencing agents, and we have to look at future trials. Thank you.
Yeah. Thank you, Dr. Deepak. And just one or two queries from my side. So in which dosing you prefer 20 or 25 milligram per meter square? In which dosing you are comfortable?
Yeah, I'm being using 20 milligrams per meter square with growth factor support in all patients, sir.
Okay. So side effects which you are challenging, what you are facing, that is the most dreaded or most fearful. Are you aware?
Actually, so
neutropenia.
Most of the patients who tolerated docetaxel, when I introduced cabazitaxel in their further lines of treatment, fortunately, all of them have tolerated it well. In patients where I had to resort to a weekly docetaxel regimen, I'm facing complications with cabazitaxel 3-weekly regimen. So in that one particular group of patients who were not able to tolerate the 3-weekly docetaxel and were on weekly docetaxel, when I was introducing cabazitaxel in their treatments, they had significant complications and had to reduce dose in these group of patients.
Is there any 2-weekly regime for this cabazitaxel also?
There is one 8 milligram per meter square regimen, if I was not wrong, sir. But I not use that in practice. There was one Indian study which did 8 milligram per meter square, if I'm not wrong, on a weekly basis.
So in which line, first line after the docetaxel failure, do you use the upfrontly hormonal or do you use the cabazitaxel in second line? Where you this molecule stands?
So I use one hormonal agent, one chemotherapeutic agent, and then I use cabazitaxel in practice, sir. I do not, the third line would always be cabazitaxel. I mean, the second line would always be cabazitaxel, but I would introduce both hormonal therapy and docetaxel and then only use cabazitaxel.
Okay. Fine. Yes. Thank you, Dr. Deepak, for this wonderful talk and clarity about this molecule on cabazitaxel. Thanks for my invitations.
Thank you, sir. Thank you, sir.
Yeah. So for the second talk, I will invite Dr. Pulaskar. He is consultant medical oncology in RR Command Hospital, Delhi. And for this, the topic is mapping ideal drug sequencing and management of metastatic CRC settings. So he will enlighten about this ideal sequencing in metastatic CRC settings. So over to Dr. Deepak Pulaskar.
Okay, thank you very much for this invite. And I uh, I think there is, I must first apologize to the organizers. I'm quite sure I must have rubbed somebody the wrong way for getting this topic,
No,
which is
it's
about.
okay. You can start. You can. It's fine.
Okay. Okay. So let us go with the topic. So we all know colorectal cancers, a huge disease in the West, and but in our country, it's not a negligible problem at all. It's the fifth common cancer that we have here. But if you look at those graphs between the incidence and the mortality, that seems to narrow in our country, reflects probably the lack of screening that is more prevalent in the West. So let us talk about metastatic colorectal cancer. It is currently, let us accept that it's currently incurable, and I really hope the future proves me wrong. But the aim of the treatment remains palliation, control of symptoms, control of tumor growth, and an attempt to lengthen the survival. So how do we sequence our therapy? To sequence our therapy, we need to know a few prerequisites. We need to know our patient, we need to know the biology of the disease, and we need to certainly know our drugs and how to use them. So looking at the patient factors, we are all well versed with the performance status, the age, the comorbidities, hepatic and renal functions will guide whether as to what the chemotherapy you can use. And all of you are aware of what are the contraindications for bevacizumab: recent surgery, wounds, arterial thromboembolic disease, hemorrhagic brain metastasis, hemoptysis, though its relevance in colorectal is not very great. If we look at the disease factors, we can look at whether it is oligometastatic. Are we looking for a conversion therapy? Are we planning a metastatectomy? Will it be together along with the primary surgery? Will it be staged? Then we certainly need to know about the RAS, KRAS, NRAS, BRAF, and about MSI and the MMR status. Tumor mutational burden probably in second, third lines. And an important thing is whether it is a right-sided versus a left-sided. Now, this was a beautiful kind of a study, which kind of looked at a multivariate models of what really are prognostic markers. If you look at the left side, you find that it is the rectum, the sigmoid colon have a better prognosis compared to the right side, and especially hepatic flexure seems to be doing pretty bad. Other than that, mucinous or signet histology, BRAF V600 mutations, KRAS mutated status tend to give a poor prognostic markers. Not only prognostic, so some of them are predictive. Like BRAF V600E mutations, KRAS mutations, NRAS mutations are predictive whether you can use your EGFR directed therapy. So coming to the drugs, what are the drugs that we got? The drugs that we know are the chemotherapies, the monoclonal, whether they be directed against EGFR or VEGF-A, and immune checkpoint inhibitors is the thing that is in vogue today. And later on in so third line, probably second line, probably multi-targeted tyrosine kinase inhibitors. So let's begin with the chemotherapy. The story begins in 1957 when this was published in Nature about a new kind of drug that was invented, and it was later patented. So this was the fluorinated pyrimidines, and it is from 1957 onwards till about 2022 today, we are still with the fluoropyrimidines. They form the backbone. So whether it be in the form of 5-FU, leucovorin, capecitabine, tegaferuracil, or S1. Now, other two drugs which are very important is irinotecan, which has a single agent activity against colorectal cancers, and oxaliplatin, though it does not have a single agent activity against colorectal, along with 5-FU and leucovorin, it is certainly very effective and useful drug, and we are all aware of it. Now, choosing a chemotherapy backbone. So, it could be a single drug, it could be two drugs, it could be three drugs. These form our basic backbone of whatever we are going to add on it. So, single drug at our center, it's an unfit patient, some ability to tolerate chemotherapy, probably who is MSS stable or MMR proficient and HER2 negative. Probably a single agent. Most of the times at our center, we go with capecitabine as a drug of choice and follow up the patient with that. Probably when general condition improves, and we have had a few patients who improved later on, we could give combination or add something else to such patients. Now, this was a very interesting by Alex Grothe and their colleagues, when they said that as you keep on increasing the number of patients who receive all the three drugs, the median OS keeps on increasing. If around about 60 to 70% of your patients are receiving all the three drugs at any given time during the course of their treatment, your median OS tends to reach up to 20. So now the question remains that how do we do this? So do we use dual drugs? Do we do a sequential drugging? Do we use all the three drugs upfront? And so we'll go through this in a very very fast because we are constrained for time. So if we look at first line, if you are using dual, you have got FOLFOX versus FOLFIRI compared to 5-FU, and if you compare oxaliplatin with FOLFOX, you find that there is a PFS benefit. Again, FOLFOX, irinotecan, there is a PFS benefit. I would like to remind you at this point that there was no OS benefit that was seen at this point. Now, if you look at capecitabine and irinotecan, it doesn't do as well as the FOLFOX IRI does. Probably one of the reasons why, if I am going to choose a backbone and I want to use an irinotecan based backbone, I would probably stick to FOLFOX rather than capecitabine irinotecan. Though I'm quite sure many centers everywhere are using CAP-IRI, and we have used it in a few cases ourselves too. But if we go by the studies, then probably if you are using irinotecan, you should be using a 5-FU backbone. If you look at what is the difference between them, whether you give FOLFOX first or whether you go FOLFIRI first, followed by FOLFOX and FOLFIRI, well, the overall survival curves do not change. They are literally hugging each other all the way down. So basically what it comes down is what is the tolerance. There's a page, you have more amount of neutropenic fevers in irinotecan group, diarrhea in the irinotecan group, whereas and alopecia in irinotecan group, whereas it is neuropathy, which is much more in the oxaliplatin groups. But whereas if you look at the partial versus complete responses, you will find more or less the same. Time to tumor progression on first line, again, more or less same. There is nothing much to choose as far as the efficacy is concerned. But you might like to choose based on the anticipated side effects and what is your performance status of the patient. Does he have a coexisting neuropathy? This forms an important part. Now there's data for why not use all the three drugs together. Now, this was a trial which was published in 2007, and they used FOLFOX IRI against FOLFIRI. So as you can see, there is a certain amount of benefit, both in the PFS as well as in OS. And this was an important study that came up. But before we jump to two drugs, three drugs, I would like to remind you of two very beautiful studies that have happened. First was the Cairo study, wherein we used capecitabine, irinotecan, and oxaliplatin in a sequential, and it was compared against CAP-IRI versus CAP. More or less, whether you do sequential or combination, you tend to have the same overall survival. This was the MRC focus. MRC focus was complicated. They changed their endpoints midway because the standard therapy had moved on. But at the end of the day, if you look at it, again, other than capecitabine and irinotecan, FOLFIRI and irinotecan, that is the 5FU irinotecan seems to be doing slightly better. Leaving this backbone there, let's come what we can add on to them. So what we can add on to them are the monoclonals. We are looking at VEGF or EGFR directed monoclonals. So we first come to bevacizumab. All of you are aware of it, humanized monoclonal antibody against VEGF-A. And the numerous trials, they have compared it against infusional 5FU and leucovorin, against Folfox or Xelox. And more or less, if you look at the data that comes, it basically favors the bevacizumab arm over the chemotherapy arm alone. Now, this was a trial in which, again, chemotherapy versus alone versus bevacizumab versus chemotherapy. There is a numerically small but statistically significant difference in the median OS from about 16 months to about 18.7 months. Now, chemotherapy with bevacizumab, we have had multiple trials that are there: TRIBE, Bolivia, CHARTA, STEAM, and TRIBE2. All the data was kind of patient individual data was taken in, and we could see if we could add bevacizumab to a 3-drug combination and how did it compare against a doublet with bevacizumab. So coming back to this, we see that at the end, especially if you look at the data from TRIBE and TRIBE2, you see that there is a benefit when you add bevacizumab even to a 3-drug backbone, that is folfoxirine. The same in a Kaplan-Meier chart, you can make out the difference. Like I say, statistically significant, numerically not so great, but still there is a benefit that is seen. If we come to the other monoclonals, we are talking about EGFR-directed therapy. It is either cetuximab, panitumumab. They basically act by the steric interference with ligand binding site. So cetuximab is a chimeric, so more amount of anaphylaxis, more amount of infusion reactions, whereas panitumumab, not so many. And both of them are approved for use only in wild-type KRAS and NRAS and BRAF V600 unmutated. So these are the important distinction there. Now, if we add them cetuximab to FOLFIRI, there's a trend towards better survival, whereas PFS, there is definitely a benefit which is seen in wild-type KRAS. But cetuximab with Folfox, though the initial trial that was published in JCO showed that there was a difference in the KRAS population, we have had two kind of negative trials, MRC Point trial and Nordic 7 trial. So might not be a very good thing to combine cetuximab with oxaliplatin. Probably if you are going to use cetuximab, maybe irinotecan is the backbone that you should be looking at. But the same is not true for panitumumab plus Folfox. When you are using panitumumab, you can add it to Folfox, and you certainly have a benefit in OS as well as in PFS that you can see. So how do these come head to head? How do we choose? So this was the CalGB SWOG, and this is in left-sided colonic cancer. Fire trial that came out basically showed that both of them are equivalent when they are used in fire. Hello, am I audible?
Yeah.
Okay, I think I was lost for a while. So, okay. So, how do we choose? Now, like I said, the factors that we have to take into account are fitness of the patient. What is the MI status? Is it high? Do we have RAS and BRAF mutations, HER2 primary can have to bevacizumab. Do we have a requirement of rapid response? Whether the patient has PS comorbidities, and whether he is a fit patient or will tolerate chemotherapy or not tolerate the chemotherapy. Is unable to tolerate intensive therapy, we need to see if he can actually tolerate in all. If there is no, if he is unable to tolerate it, whatever be the reasons, the best supportive care should alone be offered. In case the patient is able to tolerate some type of systemic therapy, then the first step would be to look at the MMR or MSI. So is it MSI high? Yes, the patient goes for pembrolizumab. We have that study of pembrolizumab versus chemotherapy that was published in EJM, which supports us there. Or if the patient is MSI stable, then look at HER2 news, whether it is overexpressed. If it is yes, we have exciting data coming up there. People have used HER2 trastuzumab, TDM1 trastuzumab deruxtecan as an option there. And if we do not have HER2 overexpression, probably our next step would be a single agent fluoropyrimidine with or without bevacizumab, depending upon the patient's condition. Now we have a fit patient here. Again, the fit patient here, the first algorithmic approach would be to look at the MSI, whether the MSI is high, if high, the patient should go for a pembrolizumab monotherapy or immune checkpoint inhibitors. The next step, if it is not if it is MSS or we need to look at RAS, BRAF, and mutational status and the site of the primary tumor. So we need to see if the patient can tolerate intensive therapy. Is the patient fit? This would be a typically young patient, have no comorbidities. He's got good hepatic and renal functions. And we think that we have a patient this way. RAS, BRAF, and if it is a left-sided primary tumor, we assess whether we can or we cannot give bevacizumab. Based on this, of course, you can give a chemotherapy doublet plus cetuximab or panitumab, or you can give a chemotherapy doublet plus bevacizumab, or you can go for FOLFOXIRI with or without bevacizumab. FOLFOXIRI with or without bevacizumab, we at our center have used it on quite a few patients here, and especially those patients who operable later on, and the now not if a chemotherapy or we come back to right-sided primary, or we have
Hello. 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 Surbi, I am audible.
Yes, sir, you are audible, sir.
So I think
Sir, I
network.
think, I think Dr. Deepak's network is very low. Sir,
So-
can we start the next talk?
Okay.
Because we are running off short of time.
So thank you, Dr. Deepak. So we will move on the next part, that is the panel discussion. For this, I invite Lalit sir for conducting this panel about this management of metastatic CRPC. For this, I invite Dr. Lalit Sharma, who is medical oncologist at Manipal Hospital, Jaipur. Dr. Jitendra Pehlajani, medical oncologist at HCG, Jaipur. Namaste. Dr. Anu Raj Purohit, he is consultant medical oncologist at NIMS Medical College. Dr. Ankur Punia, he is assistant professor at Mahatma Gandhi Hospital, Jaipur. Dr. Kalpesh, he is medical oncologist at Hemato-Oncology Clinic Private Limited, Ahmedabad. And Dr. Ajay Singh, the medical oncologist at Tata Memorial Center, Mumbai. So I invite all panelists, and sir, over to you, sir.
Thank you. Thank you so much, Dr. Divesh, for introduction of the panelists as well. And I welcome all the panelists and hope that we all will learn from each other much better than what we know. And let me start with the first slide. Surbi, can you please change the next slide, please? Next slide. So we all know about the prostate cancer drug development, that after the local therapy, we all use the androgen deprivation therapy. And then we have heard the first talk also about use of enzalutamide, abiraterone, docetaxel, and cabazitaxel. So these are 4 or 5 things we will be discussing. Next slide, please. So let us come to the main thing, and I'll start with Dr. Ankur Punia. Dr. Ankur, what are the factors in consideration for initiation of treatment of CRPC in metastatic setting?
We have to see a lot of factors. First of all, patients, we have to look at the patient, sir, first of all. What is the condition of the patient? What is the expected survival of the patient? So that all depends what kind of, whether we can give just a simple therapy or some more hard therapy. So what is the patient general condition, comorbidities, and secondly, what kind of therapies patient has already received? Because in CRPC setting, whether he has received any chemotherapy or whatever in the CSPC setting. So most, I think, important consideration are the previous therapy and the comorbidities and the expected survival of the patient.
I think that is very right. And Dr. Jitendra, want to add something out of all these things?
I will pitch in the age, the disease burden, and third thing, any family history. These 3 things should be kept into mind when we are planning any treatment.
Right. Very right. And somebody else wants to add anything in beginning of the treatment for metastatic CRPC? Dr. Ajay Singh, you are from TMH Mumbai. So in metastatic CRPC, any additional thing you do?
Good evening, sir. Most of the points have been covered. So generally in metastatic, we just look for the genetic also, or genetic counseling part. It's because now we have BRCA-directed therapy and MSI also. So these also factors we take into consideration while deciding therapy for metastatic CRPC.
Very, very right. So let us start with the Dr. Anu Raj Purohit. Dr. Anu, how do you prefer the treatment beginning of metastatic CRPC if a patient comes to your clinic?
Okay, so I'll see the patient status, what are the comorbidities, age of the patient, and what therapies we have already used in HSPC status. So along with that, I'll go for genetic MSI testing, and then I'll decide my treatment.
Right. Can I have the next slide, please? So this is the NCCN recent guidelines, and we can see that NCCN suggests that patients who are having CRPC imaging studies negative but has got distant metastasis, we continue the ADT and we try to maintain the testosterone level in the castrate level. So Dr. Kalpesh, may I ask you that how frequently you measure the testosterone, and do you continue the ADT in all patients?
So as of most of the patients who have undergone surgical castration as a part of the radiation treatment, and very few patients are on GnRH antagonist. We generally measure testosterone, but we continue ADT and monitor PS at every 3-month interval.
So does any of the panelists want to say that the continuous ADT versus intermittent ADT? Dr. Lalit Sharma, can you comment on that? You continue for these patients are surviving for many years. So you continue with the ADT or intermittently you stop it and you keep a watch on testosterone level?
Well, sir, we are continuing ADT, but this very well could be considered. But in our general practice, we are continuing with the ADT despite castration level testosterone being.
So does anybody measure the testosterone level also? Because this also has been like having a lot of significant side effects. So there have been few papers indicating that the intermittent androgen deprivation therapy also is into practice since these patients are now living for longer period. Dr. Ajay Singh at TMH, do you do that testosterone level and intermittent ADT? Dr. Ajay, can you comment on that?
Sorry, sir. So right now, sir, there is some data which is suggesting there will be some advantage with the intermittent dosing, but still this is not yet practicing at least right now. So we are still in preferably using a continuous dosing, but maybe only in circumstances where patient is not tolerating ADT very well, then we may consider intermittent. But otherwise, right now our trend is them to continue continuous androgen depression therapy.
Very, very right. That we all continue, in fact, and we try to maintain the castrate level. But in patients who are not tolerating, we try to modify the overall thing in these patients. Question is about the PSA. No identifiable progression of disease, but the PSA is increasing. So any consideration you give in clinical practice of the PSA doubling time?
PSA doubling time, sir. Yes, we monitor the PSA doubling time, and but more importance right now we are giving to the symptomatology in CRPC stage. In CHPC or HSPC stage, we give importance to this doubling time. But when it comes to CRPC, sir, we are more concentrating towards the symptomatology and planning accordingly. We are changing our therapy. But still, we need to monitor means the doubling time. At least for monitoring purpose, we are monitoring. But major in during CRPC stage, we are not just based on the doubling time. We are changing the treatment. I think someone also can suggest means how they during CRPC stage how they prefer to change the therapy or monitor the patients.
So I would add that particularly this PSA doubling time has been used now in the most of the trials which were not non-metastatic CRPC, like for all the indication in which this apalutamide and all these were approved. They use this particular criteria that they defined a criteria of 9 months, less than 9 months, or more than 9 months. Based on that, they started. But it's a little bit a controversial thing because M0 CRPC, we don't, the PSMA PET was not a standard of care. And we might pick up a lot of, indolent meds which might be there as the PSA starts to increase if we do PSMA PET regularly in all these patients. So yes, for patients who is not symptomatic and PSA just growing slowly, it's better to just observe rather than to just immediately change therapy and to run after PSA because just PSA has risen from 2 to 3 or 2 to 4 slight increase. So yes, for that criteria, but this has now gained more important, particularly in this setting only of this M0 CRPC.
I think Dr. Ankur has brought very, very relevant point that the prostate cancer is one of the slow growing tumor. So just based on PSA report, we should not immediately jump on changing the treatment because these all are elderly person with a lot of comorbidity and we have limited amount of drugs available to us and all these are sometimes leading to toxic side effects. So we need to be having reservations of changing treatment based on PSA alone. That is very, very relevant point to be noted. Thank you, Dr. Ankur. Can I have my next slide, please? So next is very important, and let me start again with Dr. Jitendra. Dr. Jitendra, if a patient comes to you with metastatic CRPC setting, then when do you test for the biomarkers, especially the mutations? You test or you don't test?
So if for young patient, I usually do BRCA or suggest BRCA whether they are not going to do it or not. Otherwise, TMB and all those things I will keep it for later. Means MSI we can do, but TMB I don't think I will do it.
All right. So anybody doing TMB and all those molecular MSI and other tests regularly, or we do only BRCA test where we have got a targeted drug? Dr.
Sir, I would
Kalpesh,
prefer to do,
Ahmedabad? Yeah, Ankur. Ankur, please
sir,
go ahead.
yes, sir, I would prefer to do HRR testing rather than just BRCA testing for this subgroup, because the PARP inhibitor study they used I think 12 gene panel of HRR genes. So it's better to go for HRR rather than just BRCA.
And thank you. That is very relevant that rather doing only BRCA, we do HRR so that we can have broader panel and we can have much wider applications of the PARP inhibitor. So Dr. Kalpesh, may I ask you that do you do biopsy from the metastatic site or you take the previous blocks into consideration?
Generally, it is very difficult to biopsy from bone lesion, and it is also not reliable for the testing. So either liquid biopsy, the blood sample, or a previous sample of biopsy might be we have to try with. And if visceral mats is available, nodal mats or something else, then we can do biopsy from the same lesion. But in practice, generally we do not biopsy lesion, and we start treatment upfront.
Thank you. Dr. Lalit Sharma, if a patient comes to you and in metastatic CRPC setting, if the patient develops very rapid deterioration in the form of having florid visceral metastasis, do you do biopsy or you sort of change with the available treatment protocols?
Also, we would consider doing a biopsy in such a situation because there has been this rapid deterioration and there is always a thought going on or back of our mind whether the disease has changed its course and it has developed some neuroendocrine differentiation. So to rule out a small cell differentiation, we would like to go ahead with the biopsy in such a situation.
Yeah, I think that is also very, very important message that in patients who are having rapid deterioration, we do a biopsy so that any change in histology from the sort of less aggressive to more aggressive, like we are treating currently a patient who was sailing through well for more than 2.5 years, and suddenly this patient had florid metastasis in liver, bones, and soft tissue, and we did a biopsy, and it was the small cell carcinoma now in fact. So it may be a change in the pathology also. So we do a biopsy, and it is documented that if you do molecular test, including HRR test on the metastatic side, the yield is much better. And as Dr. Kalpesh has mentioned, the bone metastatic site to biopsy, in fact, remains difficult, and especially the molecular testing after decalcification also becomes a challenge. So we prefer not to do a biopsy from the bony site if possible, and we take it from visceral or node or soft tissue component for the biopsy. Next slide, please. So we have heard about this docetaxel plus prednisolone. The other way is mitoxantrone plus prednisolone. So how many of you have used mitoxantrone? This is a bit older drug. We have used quite often. But how many of you have used and what is your preference at this point? Ankur, can you answer that?
So in the study, sir, it was shown that docetaxel combination was better. So we use docetaxel now. I have never used mitoxantrone in prostate cancer as such.
Very right. So it is going in fact out, and it has been very clearly mentioned in this NEJM article that the docetaxel improves the rate of response, PSA, as well as quality of life and improvement in the overall outcome as compared to mitoxantrone. But still, this is an option we should keep in mind. Of course, all these older options are getting wiped out from the NCCN guidelines also, but we have used in fact in many patients. Next slide, please. So the next is about the newer or the second generation hormone therapies. So when do you use, let me start with Dr. Anurag this time. Dr. What are your thoughts on these newer hormone therapy? When to start and how do you place them?
Okay, sir. So if I use previously chemotherapy in form of docetaxel, then I'll use the abiraterone or enzalutamide based on the patient's status. So mostly if patient is young, so most of the time we use docetaxel in HSPC setting, and then we switch to hormonal agents.
So you prefer Enja or you prefer Abiro?
I prefer abiraterone, sir.
Any specific reason for that?
So in studies or as per experience, what we have heard or we have seen that Enza still works if I already use Abira, but the reverse is not true, or the data is not in support of that. So I prefer Abira over Enza.
Yeah, I think that is also very, very relevant that if you place these drugs in a proper form, the outcome will be better. So if you place Abira before Enja, the Enja will be working in fact. But if you reverse that, like you put first Enja, then response with Abira will be not very good. So that is also very, very important topic. So next slide, please. So I think this is very relevant that which drug is to be used, Abira or enzalutamide. Next, please. Next slide. So we can see in the chart in these two studies, it was mentioned that the Abira and the Abira plus prednisolone or enzalutamide. So the median overall survival enzalutamide was 35 months and Abira also it was 35.3 months. But the sequence is very important. So we prefer to use first Abira and then put on Enja in fact rather than the reverse order. Next slide, please. So coming to the second line, like if you have used Abira or the Enja, what about the second line therapy? So I'll ask Dr. Ajay Singh in fact. Ajay, what is your practice at TMH? Dr. Ajay, are you?
Sorry, so in second line, yes, sir. So in second line, it will depend whether we have given taxane in the previously therapy and in the first line, what he has received this newer hormonal therapy. So if he has not exposed to the taxane, so I think we will prefer docetaxel or cabazitaxel. And if it is means most of the patients, we see some of the patients are not very fit. So we are sometimes using lutetium therapy also in the second line. But if you given choice, the patient is very fit, so we will prefer taxane and we will keep lutetium therapy or lutetium therapy later in the later line. But sometimes we see some patients are not very fit for giving taxane based therapy, so we prefer to give lutetium in the second line.
Very right. So all these radionuclide therapies we keep in fact reserve, and usually we use them as last in fact rather than upfront. And lutetium and the actinium is coming up very well in the metastatic setting, but still as clinicians, as medical oncologists, we keep them in the as a last resort. And Dr. Ankur, any thoughts on whether cabazitaxel first or docetaxel first?
So I prefer to give possible docetaxel first, because if you compare toxicities, we are much more familiar with using docetaxel. So just a preference, because I have seen that cabazitaxel is not that much tolerated, particularly in the older patients.
Right, very right. Dr. Kalpesh, if docetaxel be used, you use 3 weekly or weekly? Any preference?
If traveling is not an issue, then I will prefer weekly. If patient is coming from remote places, then 3 weekly is preferred.
So I think there has been no significant difference in the weekly versus 3 weekly, and docetaxel we all are exposed and we all are using for more than a decade now. So
Can I
we all can
intervene,
manage.
sir? Can I
Yes,
ask,
sir.
sir, is there any panelist using the twice weekly, 2 weekly regime of docetaxel?
Yeah,
Yes,
I prefer to give every 15 days.
I think at least I think, sir, at our place also we are preferring using 2 weekly.
So what dosage you give 2 weekly?
50 mg per meter square.
Pardon, can you repeat that?
The weekly 25 milligram per meter square, 2 weekly 50 milligram
50 mg per meter square, sir.
and 3 weekly 75, 25, 50, 75.
Right. In fact, but again, it depends on where you are practicing and what type of patient you are seeing. Like in the various government schemes, they allow only for 6 cycles. So we try to give it 3 weekly. And Divesh is smiling that weekly will be much better for his patients. Those who are coming in sort of good status, they prefer weekly and daycare based, less toxic side effects. Although, so can we go for the next slide, please?
So sorry to interrupt, but we have only 5 minutes left.
Okay, so we'll go faster. So I think this we have discussed about the abiraterone or the ENJA. ENJA works in all sort of visceral and non-visceral metastatic disease. Next, please. Next slide. So we have discussed about the cabazitaxel. So Dr. Jitendra, cabazitaxel toxicity, which dosage you are using and how is your experience?
Sir, 20 mg per meter square is good enough for Indian patient. More than that, probably febrile neutropenia expense is high. This is what I have felt when I started using 25. I moved slowly to 20 only, and at 20 it is quite tolerable, although not as good as dosing, but yeah, it's quite tolerable.
Right. Anybody using, like Dr. Ajay mentioned, probably 25 mg per meter square they are using regularly, but we also faced that 25 milligram per meter square becomes toxic. And we had few patients who discontinued. In fact, even after first cycle, they said we will not go for further treatment. Next slide, please. Next, please. So I think we have discussed about the sequencing, and these all are NCCN guidelines, and we have covered most of these points. Next, please. So these are factors we have discussed these parts also, and we have discussed the biomarkers also and various important things related to that. Next, please. Yeah, next slide. So I think we have covered many of these aspects. Next slide. Next. So I think we will come for and cover up partly. Next slide, please. Yeah, this is the important thing, that the genetic testing. So let me start with Dr. Lalit Sharma, that what percentage of patients who are undergoing genetic testing for prostate cancer in clinical practice?
Well, those are, we haven't compiled our data, but for a rough estimate, I believe less than 25% of the patients are going.
Less than 25%. And Dr. Ajay, in Tata Hospital, what is your practice? How many percentage of patients are going for genetic testing?
So right now, sir, means we started practicing regularly, but still means as overall we are seeing only 10 to 15% patients we are able to do genetic testing. But now maybe in coming years it will be, rise further. But because now we have adapted to do genetic testing in all prostate cancer patients. But till now maybe a maximum maybe up to 15% patient we are able to do genetic testing.
I think this is very correct statement, that most of us have just started doing the genetic testing in prostate cancer. So we do it in probably 10 to 20% patients. And many times we feel that if the patient cannot go for the targeted therapy, PARP inhibitor, then probably this will not be much useful. Next slide, please. Why genetic testing is important? Because almost quarter of these patients with metastatic prostate cancer, next slide please, almost 25% of these patients can be having some genetic BRCA or BRCA related genetic mutation testing positive. Next slide please. Surbhi, can we change this slide please? So we can see that almost 25% of these patients, they might be having the DNA repair gene defect in prostate cancer. And we have drugs available, and Indian drugs are also available now. So this becomes relevant that we do, especially in the subset of patients where there is strong family, and we do it from the metastatic site if possible, rather than from the primary old wax blocks. Next slide, please. So this is very relevant, that when do we, so we have discussed that we try to do in metastatic site, but preferably not from the bone site, we do it from other sites. Next, please. So this is very important. And we have discussed that patients who are having genetic defects, we divide them in risk categories, and then again based on that we move forward and we do HRR testing, MSI testing, and we move forward if finance is not a barrier. Next, please. Should we have it done or we have 1 or 2 more minutes?
Sir, 1 or 2.
Devesh, do we have more time or should we wind?
Sir, 1 or 2 more minutes.
Okay, thank you so much. So this slide is very important, that when do we do all this HRR gene testing, whether do we in the upfront setting or when the patient develops metastatic disease. So let me start with Dr. Kalpesh. Dr. Kalpesh, when do you do the genetic testing, HRR genes? If a patient comes to you from strong Gujarati, very, very powerful Adani family, when do you do HRR testing in metastatic setting?
So MCRPC.
Yes. You do it MCRPC setting only, no upfront?
No.
Does anybody prefer to do it upfront also? Any advantage of doing in upfront?
No, Mr. Now, as per actually guideline, we should start doing genetic testing from the high risk early localized cancer also. So at least in metastasis, I think we should strongly recommend all the patients to do genetic testing, because in near future everyone will need some help and therapy will be going to be affordable for each patient. So at least means as per if we go by our guidelines, so from high risk early stage tumor we should doing the genetic testing, and I think from metastatic stage definitely we should advise all the patients to do. And another point, sir, we are doing both germline and somatic both testing we are doing together. At least if not, we are starting the germline and then if it is coming negative, we are moving to somatic. But we are advising both at least in all metastatic patients.
So Dr. Ajay has brought very relevant point in discussion that if we test upfront in high risk patient, it becomes important for us to understand and the availability of various drugs, and not only the patient, but their family members can also be sort of counseled for any possible genetic defect. And males and females both can be sort of screening can be done earlier, like we do for the breast and ovarian cancers. Next slide, please. So this we have discussed about the ctDNA versus the tissue. So Dr. Anu, can you throw some light that are you comfortable with the blood or you prefer still the tissue?
I still prefer the biopsy only because the sensitivity is not that good as we see in the lung setting. So
Very
I still
right.
prefer that.
So the sensitivity as seen in the lung for EGFR and the mutations, it is not same in prostate cancer. So still we prefer to do it on tissue rather than doing on the blood. ctDNA is still not that good. Next slide, please. So I think we have covered most of these things. Next, please. Now this HRR gene also we have discussed that metastatic setting is better. Next slide, please. Next, please. So I think we have done with most of these issues, and with this I conclude the panel. And I think we have discussed the hardcore science as well as some practical aspects. And we have learned that how to maintain, how to manage the metastatic CRPC patients. And we have understood that the genetic markers are equally important. And we need to test these upfront also so that we can have better and better understanding. With this, I thank Dr. Lalit Sharma, Dr. Jitendra Peljani, Dr. Anuraj Purohit, Dr. Ajay Singh, Dr. Ankur Punia, Dr. Kalpesh, and at the end, Dr. Devesh, and all the team, in fact, Surbi and everyone. Thank you so much.
Thank you, sir.
Over to you, Dr. Devesh.
Sir, unmute yourself, sir.
Sir, Devesh, sir, you are unmuted. Please, sir, unmute.
Sorry. Thank you, sir, for attending today's sessions and sparing your times and valuable guidance. And definitely we will got benefited and we will use this clinical practice. I think this is more important for us in our day-to-day practice. Thank you, sir, and thanks all panelists. And for this next talk, I will invite Dr. Rakesh, who is consultant medical oncologist at Hyderabad, and he will deliver the talk on the management of metastatic RCC. So as we know that the overall segment of the RCC have been changed from targeted to immunotherapy plus targeted therapy combinations. So over to you, Dr. Rakesh.
Sir, Dr. Rakesh is not here, but we have his recording, sir.
Okay, fine.
Good evening to all. Thank you, organizers, for this wonderful opportunity. So I'm going to discuss management of metastatic renal cell carcinoma in the next 15 to 20 minutes or so. So this is the brief outline of my discussion today. I'm going to look at the burden of renal cell carcinoma, metastatic renal cell carcinoma in the community, and look at the decision points for initiation of therapy, which includes risk stratification and rationale of choice of therapy. We look at the data for both frontline, second line, as well as the non-clear cell histologies. And we will end with some of the ESMO 2022 updates, the recently concluded fiscal meet. So this is the burden of metastatic renal cell carcinoma across the world. As you can see, the incidence rates vary widely. Basically, it's a disease which is much more commonly seen in the westernized population. In the European continent, as well as in the North American continent, as you can see, the incidence rates ranges from around 10 to 12 per 1 lakh population. And in Indian subcontinent and the African continent, you can see it is around 1 to 2 per 1 lakh population. And numerically, globally, we can see nearly 4 lakh new cases and nearly about 1.7 lakh deaths annually because of the renal cell carcinoma. In India, around 17,000 new cases, around 10,000 deaths annually because of the renal cell carcinomas. Coming to the stage of diagnosis, nearly 20% of these renal cell carcinoma patients do present with de novo metastatic disease, and another 30% usually get back with the metastatic disease despite curative resections. So in total, we are looking at nearly about 30 to 40% of the entire cohort of renal cell carcinoma patients eligible for systemic therapy because of the metastatic disease. So these are the main biological features of renal cell carcinoma. The significant majority, nearly 85 to 90% of all the renal cell carcinoma belong to the clear cell renal cell histology. And even in the clear cell renal cell histology, nearly about 85% of patients do have VHL mutations, either germline or somatic. This could be mutation, deletions, or epigenetic alterations in the form of hypermethylations. And there is also a much more commoner chromosomal abnormality, which is the 3p loss, which actually has BAP1, ZD2, other genes which can be mutated because of the 3p loss. So in this set of patients with the VHL mutations or 3p loss, there is hyperproduction of the VEGF cytokines and other pro-angiogenic cytokines, which results in an exacerbated angiogenesis in tumor microenvironment. The other set of patients, which are a minority, are having the mutations in the mTOR genes. This results in a metabolic tumor, which is having the resistance to apoptosis, thereby having a tumor survival. So coming to the decision points when patient present to the clinic with metastatic disease, these are the historically validated risk factors, hinge criteria, which has been validated for the use in the TKI therapy, which is targeting the VEGF inhibition. And as of now, none of this have been prospectively validated in the immunotherapy or immunotherapy TKI combination. But in the absence of those validated nomograms in the present era, we continue to use the same clinical risk factors for stratification of patients in the clinical trials as well as the routine clinical practice. These include performance status of patients, time to diagnosis of metastatic disease, and the lab features, which are basically trying to understand the inflammatory makeup of the patient. We're basically looking at the neutrophilia, thrombocytosis, hypercalcemia, and low hemoglobin. These are basically trying to identify those patients who are having an inflammatory state. So based upon these risk factors, patient can be grouped into favorable, intermediate, and poor risk. And based upon the nomogram, we can understand that median survival can range anywhere from 8 months to 43 months in the poor risk as well as the favorable risk, respectively. In the present immunotherapy and TKI combination era, we are not only looking at the IMDC risk stratification, but also at the histology, comorbidities, tumor load, and metastatic pattern to make the decision point of initiation of therapy. The other biomarkers like PD-L1 testing are two selectors of overall survival. They can select out for overall response rates and as well as PFS, but when it comes to overall survival, it is not a good prognostic marker. And other genetic signatures in the form of microRNA signatures, these require prospective validation and standardization and are only limited for research purposes only. So as we see in 2022, immunotherapy combinations are the present standard of care, both in the favorable risk as well as the intermediate and poor risk. You can see that this is the ESMO 2021 and this is update to that in 2022. Still, the immunotherapy and TK combination are the de facto standards of care. And in the intermediate and poor risk group, there is also a combination of ipilimumab, nivolumab, which is also having a category 1 level A evidence for the frontline utility. So these are all the 4 pivotal clinical trials that led to the approvals of the present standard of care. As we have to understand, these are having different study methodology. There are similarities and dissimilarities. We are basically trying to compare apples with oranges. Any cross-trial comparison is not going to be scientific. Let's start with some similarities. All these clinical trials have tested sunitinib as the as control arm, and these have had a superiority study design. And if it comes to the dissimilarities, we can see that the study population, which is in the CLEAR trial that tested pembrolizumab versus sunitinib, it already presented a favorable subgroups. Basically, it included only 9% of patients with poor risk and nearly 31% of patients with good risk. When you compare that with CheckMate 9ER having a significantly higher percent of patients, basically poor risk is nearly 20%, good risk only about 23%. So again, there is differences in the basic makeup of the target population in this trial, and as well as we can look at the follow-up data. And follow-up data is much more longer for the CheckMate 214, nearly 55 months, and shorter for the CheckMate 9ER and CLEAR trial, it is only for nearly about 2 years. Coming to the response rates, I think among all the 4 clinical trials, I think the absolute numbers or maximum response rates is seen with the CLEAR clinical trial at around 71% overall response rate. And only 5% of the patients were having progressive disease as a best response. When you compare that with the CheckMate 214, only 40% of patients had an overall response rate, and nearly 20% of the patients had a progressive disease as a best response. But we have to be mindful that this clinical trial, again, pre-selected a favorable subgroup of patients with a higher proportion of patients being in the good risk and lower proportion of patients with poor risk. When you look at the PFS numbers, and absolute numbers are also significantly, basically it is 24 months in the clinical trial of CLEAR, which is a TKI and pembrolizumab combination, and the immune checkpoint inhibition combination is only 11.2 months. This is what we are seeing across different clinical trials which have utilized the monotherapy of immunotherapy or immunotherapy combinations. The PFS really doesn't appear to be significantly better, but the overall survivals are better. Coming to the hazard ratio, 0.39 again is better with the clinical trial of CLEAR. If you look at the overall survival numbers, as we can see, the PFS numbers, overall response rates are better with the CLEAR clinical trial, but that did not translate into a much more significantly better risk reduction with respect to overall survival. If you look at the overall survival, risk reduction is nearly about 30 to 35% across all the clinical trials with the hazard ratio 0.66 to 0.68. So again, there is a signal here that the impact of immunotherapy and TKI combination is muted in favorable group. If you look at the hazard ratios across the different clinical trials of immunotherapy and TKI combination, you can see that there is much more benefit with the utility of these combinations in the intermediate and poor risk compared to that of the favorable risk. As we can see across the clinical trials, the hazard ratio were crossing the unity for the favorable risk and significantly better in the poor risk populations. And this is similar with the immunotherapy combination of nivolumab and ipilimumab. The hazard ratio 0.65, which was statistically significant for the intermediate and poor risk population, and the hazard ratio 0.93, which was not statistically significant for the favorable risk population. There could be a biological rationale for this. What is happening is that by applying the Hing criteria, we are labeling those patients who are having a much more inflamed physiological makeup, inflamed tumors as a poor risk patients, and these patients already have much of the T cell infiltrations into the microenvironment, and these are probably not functioning properly. And by applying the immune checkpoint inhibition, we are reprogramming these effector cells to have a anti-cancer effect. But in those patients who are having good risk, these probably have a tumor microenvironment which is an immune desert, that they don't have much of a T cells which are infiltrating to lymphocytes, T lymphocytes infiltrating to the microenvironment. And it could also be immune excluded, that it can be infiltrating, it can be in and around the peritumoral area, but not infiltrating the tumor microenvironment. So this is some amount of biological rationale that we can try to come up by the reasoning why the favorable risk patients are not being benefited much with the immunotherapy combination, immune checkpoint TKI combination compared to that of the poor risk patients. So this is the usual graph that we actually see when we are treating patients with immunotherapy as a monotherapy or combination in solid tumor malignancies. This is the graph I picked up from the melanoma clinical trials. As you can see, when applied compared to that of the control arm, which could be chemotherapy, there is no real separation of the curves in the first initial months. This could be possible because the effector cells are being reprogrammed. They are yet to have the effect on the cancer per se. And those patients who are having significant tumor burden, those patients who are having significant symptomatic burden, probably will not be benefited, because there is going to be more time for the immune effects to be kicked in and have an anti-cancer effect. But as the time progresses, there is a suppression survival impact that occurs much later, and median overall survival is thus increased, and there is a survival plateau that is observed after a few years. And we again, even in the renal cell carcinoma, trying to see long-term survivors. Nearly about 8 to 10% of patients appear to belong to these drugs, and there could be possibility of treatment-free remission and possibility of cure here again. So these are the first line conclusions. As I previously mentioned, the immunotherapy combination combos are the present standard of care in the metastatic renal cell carcinoma, both in the favorable risk and as well as in the intermediate and poor risk. But we have to be mindful that immunotherapy, when it's applied in the good risk patients, it appears that the benefit is muted, and this is because of the good risk features indirectly reflect a non-inflamed or a cold tumor microenvironment, which is not suitable for the immunotherapy. And if you look into the practical and economical implications of these therapies and lack of overall survival benefit in the good risk populations, a single agent anti-angiogenic therapy in form of either sunitinib or pazopanib is also a good therapeutic option in these good risk patients, especially if they don't have a significant disease load, or if they don't have a rapid tumor progression, or if they are having no visceral metastasis. Coming to the second line treatment, again, the prognostic modeling in second line also reflects the same practice that we do in the front line as well. The same IMDC criteria have been applied. This is again a clinical trial. It was an experience that was published in Lancet Oncology 2015. Again, the same risk grouping can be seen even for those patients who have been taken treatment, on the second line treatments. Can we improve upon the IMDC criteria? The Italian and European investigators have added newer biomarkers in the form of neutrophil lymphocyte ratio, site of metastasis, and this has been validated in those patients who have been taking second-line treatment with either nivolumab or cabozantinib. So coming to the second-line combination, this is the lenvatinib plus pembrolizumab combination in those patients who are either previously treated or treatment naive. And we can see this is the largest prospective study with mostly immunotherapy treated population, and you can see there is definitely proof of response here. The overall response rate, if you look at the waterfall plots, you can see that significant majority of these patients have responded. Nearly 60% of patients had an overall response at week 24, PFS of 12.2 months, and median overall survival, which was not reached in the time of publication. Coming to the TKI therapy after immunotherapy, we can see that there are several prospective clinical trials. This is the Meteor for the cabozantinib, tivozanib, axitinib, and Breakpoint immunosome for the sunitinib. The response rates are anywhere between 20% to 45%, and PFS is ranging from anywhere from 6 months to 10 months. So this is again a prospective trial that tested the utility of second-line TKI therapy in those patients who had a progressive disease on the frontline immunotherapy combination of nivolumab and ipilimumab. As we can see, several TKI therapy has been applied. Both first generation and second generation TKI have been applied with the overall response rate of nearly 40%. And PFS of around 8 months, and overall survival numbers, which are similar to the numbers that we usually see in the TKI therapy era in frontline setting with sunitinib or pazopanib. We are usually seeing around a PFS of 8 to 10 months and overall survival of nearly 60% at around 1 year. We are seeing similar numbers of TKI therapy in the second line treatment after immunotherapy as well. And there appears to be no difference between the application of whether the frontline, whether we are using the first generation or second generation TKI. So this is the newer drug. This is the MK6482, which is belzutifan. Basically, it is a HIF-2A alpha inhibition. This is much more heavily pretreated population. Nearly 50 patients have been tested in this phase 1, phase 2 trial. Median number of prior lines of treatment is 3. At a median follow-up of nearly 28 months, we are seeing a disease control rate of nearly 80%, median PFS of nearly 15 months. And safety profile, there are 2 distinct side effects, which is anemia and hypoxia. And as per the experience of the investigators, anemia can be well controlled with the help of erythropoietin analogs. So based upon this phase 1, phase 2 experience, there are 2 phase 3 trials which have been designed using the belzutifan as a monotherapy or in combination with lenvatinib. Again, these results are going to be really practice changing. So addition of ipilimumab to the ongoing immunotherapy is one of the strategies that has been proposed. This is testing the use of at least 2 or 4 cycles of ipilimumab when added to the nivolumab as a rescue strategy. If you look at the response rates are not very good. It is around, ranging from 4% to 14% and nearly no CR. So a rescue strategy with the addition of CTLA inhibitor like ipilimumab to ongoing PD-L1 therapy in those patients who are treated with either immunotherapy combination of VEGF inhibition did not result in a major responses. Coming to the non-clear cell histology, it's again a very heterogeneous disease. Previously, we were versed with the papillary type 1, type 2 chromophobic oncocytoma. This is basically depending upon the histological features. Now we are into the molecular era. These different subset of non-clear cell histologies have a different prognosis. They range from anywhere from very good prognosis to often dismal prognosis, as we see in the renal medullary carcinomas. They have a very distinct molecular alterations as well. For example, type 1 papillary RCCs have nearly uniform MET inhibition. So coming to the available options, this is the NCCN Guidelines 2023 version. As you can see, all the frontline treatments that are useful for the clear cell histology are also useful for the non-clear cell histology as well. However, specific treatment approaches with non-clear histology is based upon the histological subtype. We can have the immunotherapy drugs or combination of those drugs, mTOR inhibitors as the options. So this is the PAPMET phase 2 clinical trial. Basically, this is a clinical trial that was tested in those patients who are having a histologically confirmed papillary renal cell carcinomas. Patients who have no exposure to prior sunitinib have been randomized in a 1:1:1 fashion to one of the other 3 MET inhibitors, which is cabozantinib, crizotinib, and savolitinib. After the initial run, the crizotinib and savolitinib arms were withheld because of the futility or slow accrual, and we can see the primary endpoint was progression-free survival. So between April 2016 to December 2019, nearly 150 patients were randomized to 4 study groups. And basically, we can see that PFS was longer in those patients with treated with cabozantinib at around 9 months versus 5.6 months, which was statistically significant. The response rate was also better with cabozantinib at 23% versus 4%. And there appears to be no major difference in the overall survival as of now. Whatever difference we are seeing is in the response rates and PFS. Coming to the combination in the lenvatinib plus everolimus, again, this has been tested in those patients with non-clear cell histology. As we can see, the primary endpoint of the study was objective response rates. And as a cohort, the objective response rate was 26%, median PFS was 9.2 months, and median overall survival was 15.6 months. But there appears to be a signal in the chromophobe renal cell carcinomas where the response rates were pretty good at around 44%, and clinical benefit for 8 was 77.8%. So again, there was a combination of cabozantinib plus nivolumab, the non-clear cell renal cell carcinomas. This is both in the frontline setting as well as in the second line setting. Again, the patients were divided into two cohorts. Cohort 2 included only chromophobe RCC, and cohort 1 included all the other non-clear cell histologies. Again, the primary endpoint of the study was the overall response rates. As we can see in the cohort 2, the response rates was 0% compared to cohort 1, which was around 47.5%. So this cabozantinib plus nivolumab had no effect in the chromophobe RCC, but the previous clinical trial of everolimus plus lenvatinib had nearly 44% response rates. So there appears to be some amount of selection of treatment based on histologists here. So this is again patients with sarcomatoid features. Sarcomatoid features is not yet a standalone subtype. This sort of features can be seen in those patients who can be having clear cell histologies or non-clear cell histologies. Historically, when treated with VEGF inhibition, they have a very dispersed prognosis. But this prognosis, this bad prognosis, is actually negated by the utility of the immunotherapy combination or immunotherapy plus TKI combination. As we can see, response rates are on par with the clear cell histologies at around 60%. With nearly about 10% to 15% of CR rates and median PFS numbers, which are similar to that of what we see in the clear cell histologies. So now we come to the ESMO 2022 updates. I will try to update on 3 important clinical trials that have been presented in that ESMO Congress. Basically, the phase 3 COSMIC 313 trial. This was a trial that tested the contemporary protocol of nivolumab plus ipilimumab as a control arm with a triplet drug combination of nivolumab, ipilimumab plus cabozantinib. Again, basically the primary endpoint of the study was the investigator, the blinded committee, review committee PFS. As you can see, median PFS was not reached versus 1.3 months, and which was statistically significant. Overall response rates were also better at 14% versus 36%. Median duration of response and median overall survival was not reached in both the cohorts, but it comes with a significant grade 3 and grade 4 toxicities. Nearly 3/4 of the patients had grade 3 and grade 4 toxicities at 73% compared to 41% in the control arm of the nivolumab plus ipilimumab. So this is the phase 2 trial of LightSpark W03. This is basically testing the newer drug of HF inhibition with belzutifan with combination with cabozantinib. This is the cohort 1 that has been reported. The primary endpoint of the study was the overall response rates. Basically, these are the patients who have been pre-treated or treatment naive or pre-treated, and the response rates were nearly about 57% in the entire cohort, 62% in the favorable risk, and 50% in the intermediate risk. The median PFS was 30 months, which was again estimated 1-year PFS was 67%, and median overall survival was not reached, and estimated 1-year overall survival was 96%. Finally, I would touch upon this Titan RCC trial, which is basically tailored immunotherapy approach in nivolumab in RCC. Basically, it included those patients who are having intermediate and high risk by IMDC criteria, included only those patients with clear cell histologies and metastatic advanced RCC without included potential surgeries. These are the patients who are either untreated or at least pre-treated with one prior TKI therapy. And basically, there is an induction with nivolumab of around 240 mg every 2 weekly for 8 cycles. And subsequently, patients who are having a stable disease or early progressive disease went on to have a ipilimumab boost of at least 2 to 4 cycles, and those patients who are having complete response or partial response went on to nivolumab maintenance. So the primary endpoint of the study was overall response rates. As you can see, the confirmed response to nivolumab induction was seen in 28% of patients in front line, 18% of patients in second line, and the overall response for those patients who are taken nivo or nivo.
So, sorry, I think the talk is very longer. So, for next session, this is the Merck sponsored session. So for this, I will invite Dr. Preeti Agarwal. She is consultant medical oncologist at Apex Hospital, Jaipur, and she will deliver the talk on the choosing right immunotherapy in advanced urothelial cancer for optimum patient benefit. So I think after the approval of these immuno-oncology drugs in metastatic urothelial cancer, so all paradigm have been changed. So Dr. Preeti will enlighten us. So over to you, Dr. Preeti.
Yes, am I audible?
Yeah, you are audible.
Yeah. So let's start. I think I'm trying to share my screen.
Yes.
So my screen is visible.
No.
No?
No.
So is it visible now?
Yes. Right now it is visible. Okay, you can carry forward.
So thank you, sir, for giving me this opportunity to speak regarding immunotherapy in a very it's a very new topic of maintenance in urothelial cancers. So let us start. So the topic is choosing right immunotherapy in advanced urothelial cancer for optimal patient benefit. So this is the timeline of how our drugs evolved in urothelial cancer. As we can see, initially it's all began with cisplatin to MVEC to platinum-based doublet chemotherapies to addition of gemcitabine, and in 2017 we had addition of pembrolizumab and atezolizumab, and now avelumab. So optimizing first-line therapy is very important in aggressive disease like urothelial cancer. You see the first line treatment. first line treatment is very important. We can see that out of 100 patients in multiple study, only 35 to 40% patients were able to receive any form of second line treatment. We can see only 10 to 15% patients are able to receive third line treatment. So the first line treatment is very, very important in urothelial cancer, because we can see that after first line, only 1/3 of patients are able to receive second line form of treatment. Majority of patients of platinum-based first line therapy, almost 50 to 70% patients are cisplatin eligible, while 30 to 50% are cisplatin ineligible. So however, around 75% patients are platinum eligible. Around 75% patients who are cisplatin ineligible can be offered carboplatin-based chemotherapy at physician discretion, which is based on performance status, renal functions, neuropathy, and age. So how do we define platinum eligibility or platinum ineligibility in patients of metastatic urothelial cancers? So this is a survey done by Dr. Gupta of 60 genitourinary medical oncologists in the US to generate an updated consensus definition of platinum ineligibility. So they found that based on this survey, in metastatic urothelial cancer, there were 5 parameters where patients were considered platinum ineligible. The patient's ECOG performance status of more than 3, of creatinine clearance of less than 30 ml per minute, peripheral neuropathy of more than 2, NYHA heart failure of class more than 3, performance status and creatinine clearance less than 30. These criteria are proposed to guide treatment recommendation and standardize eligibility criteria for defining platinum ineligible patients. Regulatory updates for PD-1 and PD-L1 therapy in advanced cisplatin ineligible urothelial cancer requires the use of FDA-approved companion diagnostic test to detect the levels of the PD-1 in tumor tissue. Pembrolizumab is indicated in treating patients of locally advanced or metastatic urothelial cancer not eligible for cisplatin-containing chemotherapy and whose tumor express PD-L1 as determined by FDA-approved test, or patients not eligible for any platinum-containing chemotherapy regardless of platinum PD-L1 status. Similarly, atezolizumab is also approved for metastatic urothelial cancer patients not eligible for cisplatin-based containing regimen whose PD-L1 status or combined proportional score of more than 10, and or patients who are platinum ineligible. So what are the 3 options? How do we use it? First line chemotherapy, then wait and watch. And after disease progression, initiate second line chemotherapy. The other option is first line chemotherapy, switch to some form of IO maintenance, and at progression, initiate second line chemotherapy. Third is continuation of maintenance. Start with chemotherapy and IO, continue IO maintenance, and switch to initiate second line chemotherapy on progression. First line chemotherapy, almost 50 to 80% of patients achieve control on first line platinum based chemotherapy. However, overall survival is limited by chemotherapy resistance. So the median overall survival remains in the range of 13 to 15 months in patients getting platinum. So approach to maximize overall survival with IO upfront, chemotherapy for plus IO. So there are 3 studies: IMvigor study, Keynote study, Danube study. Treatment strategy: IMvigor, chemotherapy plus IO, and it was atezolizumab. In Keynote, it was pembrolizumab. In Danube, it was durvalumab plus tremelimumab. So the outcomes, the Keynote 361, this trial is a negative trial, did not meet OS and PFS primary endpoint. IMvigor, the data is awaited. However, at second interim analysis, there is no difference in overall survival. And in Danube, they did not meet OS endpoints. So addition of chemotherapy with IO in first-line chemotherapy setting does not help in improvement in overall survival. So 50 to 8 switch, and second is switching the maintenance therapy. 50 to 80% patients achieve some form of control after platinum-based chemotherapy. However, most of the patients progress within 9 months of platinum-based chemotherapy. In several tumor types, first-line maintenance therapy with an alternative agent has been shown to prolong overall survival. So testing this hypothesis, Devlin trial was designed where avelumab maintenance therapy can improve outcomes in patients who receive first-line platinum-based chemotherapy for advanced urothelial cancer. So first-line chemotherapy was given for a fixed duration, and after a treatment-free interval, they were switched to IO maintenance, and at progression, they initiated second-line chemotherapy. So this form of treatment where we have IO maintenance between chemotherapies had a maximum overall survival advantage. We can see continuation of addition of chemotherapy to IO and continuing IO maintenance and initiating second-line chemotherapy has not improved overall survival. So switch maintenance is the answer to improve overall survival. So discussing this Devlin Bladder 100 trial in detail. So what they did is it's a phase 3 randomized open label study. Unresectable locally advanced with metastatic urothelial cancer with measurable disease received first-line chemotherapy with gemcitabine, cisplatin or carboplatin, and for 4 to 6 cycles. And after a treatment-free interval of 4 to 10 weeks, the patients who maintained CR, complete response, partial response, or stable disease were randomized. Almost 700 patients were randomized to avelumab versus best supportive care alone. The primary endpoint was overall survival in all patients as well as in patients who were PD-L1 positive. The secondary endpoint was progression-free survival, overall response, time to response, response duration, disease control, safety and tolerability. So median age was 68 years, 76% patients were male, 24% patients were female. ECOG performance status was 0 in almost 61% patients, and it was 1 in 39% of patients. 55% patients had visceral metastasis, while 45% patients had non-visceral metastasis. First-line chemotherapy was gemcitabine cisplatin, and 50% patients almost. It was carboplatin plus gemcitabine in 42% patients, and or either of the two, cisplatin or carboplatin, in remaining 6% of the patients. So overall survival, we can see that overall survival and progression-free survival. So overall survival in overall population, irrespective of PD-L1 status, it was almost 2 years, 23.8 months versus 15 months with observation alone, with a hazard ratio of 0.76, with a p-value of 0.003. However, progression-free survival, it was increased from 2 months to 5.5 months with a hazard ratio of 0.54, with a p-value of less than 0.0001. So we can clearly see that both the graphs separating from each other from starting till tail, and overall survival being almost 2 years. Median overall survival being 2 years. However, in PD-L1 positive subset population, the median overall survival was more than 2 years. It was around 30.9 months compared to 18.5 months in observation arm. And progression-free survival was also increased from 2.8 months to 7.5 months. So these are very interesting graphs showing importance of avelumab maintenance. The safety profile of avelumab was consistent with prior experience of avelumab as single agent. Almost 30% patients experienced some form of adverse events that were low grade. Only 7% patients had more than grade 3 adverse event. No grade 4 or fatal event were reported. 9% patients received some form of oral prednisolone. Doses is more than 40 milligram per day. 12% patients discontinued treatment due to adverse event. So this overall survival and progression-free survival benefit with avelumab was seen irrespective of the best response to chemotherapy, whether the response was CR or PR or stable disease. The graphs were separated in all the 3 patient subpopulation. It did not depend whether the patient had what type of response to the chemotherapy. The OS, also the overall survival was prolonged with avelumab with first-line maintenance, and irrespective of number of first-line chemotherapy cycles received prior to randomization, whether 4 cycles, 5 cycles, 6 cycles, any of the cycles the patient received, the overall survival was prolonged with avelumab maintenance. Similarly, the overall survival was increased in patients on avelumab maintenance, irrespective of the duration of treatment-free interval. before starting avelumab, whether 4 to 6 weeks, 6 to 8 weeks, or more, 8 to 10 weeks, the overall survival increased in all the population subgroup. So discussing the R subgroup, like Asian subgroup analysis in ESCO-GU 2022. So similarly, induction chemotherapy patients, unresectable locally advanced metastatic urothelial cancer patients achieving CR, PR, or SD with standard first-line chemotherapy of GemCis or Carbo. Almost 147 were Asian patients in this 700 patient subgroup. Sorry.
Can we conclude within 1 or 2 minutes, Dr. Preeti?
Yeah, I just conclude. So this is, let's see, that avelumab maintenance is helpful in Asian subgroup as well. The overall survival is increased from 18.7 months to almost more than 2 years, 25.3 months. So the guidelines, we can see the guideline is also updated in patients in NCCN and ESMO and EAU guidelines. The avelumab maintenance is now the first line treatment after chemotherapy, GemCis or GemCarbo. Even there is no data for DD after DD-MVEC, but the guidelines suggest avelumab maintenance after DD-MVEC as well. So I think I'll conclude my study, this presentation. So the avelumab maintenance remains the first line treatment. I'll conclude. So the avelumab maintenance remains first line treatment as the preferred immunotherapy for metastatic urothelial cancer, or as it increases the maximum overall survival in urothelial cancer. Thank you. I should conclude here.
So thanks, Dr. Preeti, for enlightening us and very well discussed about this topic in metastatic urothelial cancer. So nowadays the practice changing segment, the chemotherapy first 4 to 6 cycle followed by the avelumab maintenance. So I think thanks, Dr. Preeti. And for next session, I will invite Dr. Manish Kumar, who is consultant medical oncologist at American Oncology Institute, Gurugram. And he will discuss about the management panel discussion about this management of advanced ovarian cancer. So I will invite for panel Dr. Varun Goyal, who is medical oncologist at Rajiv Gandhi Cancer Institute, Delhi. Dr. B.S. Ankit Nehra, who is medical oncologist at HCG Hospital, Jaipur. Dr. Sunil Chopade, he is the Prince Ali Khan Hospital, Mumbai. And Dr. Mohit Saxena, he is consultant at Narayana Hospital, Gurugram. Dr. Jyoti, he is Yashoda Hospital, she is at Yashoda Hospital, Ghaziabad. And Dr. Umesh Khandelwal from Durlabji Hospital, Jaipur. And Dr. Mukesh Chaudhary, he is Global Abhishek Cancer Hospital and Research Center, Jaipur. So I will invite all panelists, and over to you, Dr. Manish sir, for panel discussion.
Thank you, Dr. Devesh, for this opportunity. I'm indeed grateful. And you've already welcomed the panelists. So as I can see, Dr. Varun Goyal, Dr. Umesh, and Dr. Lalchand are probably not there. Rest everyone else I can see. If you are there, kindly just confirm Dr. Varun, Dr. Umesh, and Dr. Lalchand.
Sir, no, they are not there. We are trying to
Okay.
touch him.
No problem, no problem. So I just share my screen. Okay, is it visible? Is my screen visible?
Yes, yes, your screen is visible.
Yes, sir.
Okay, great. So let's begin. I must say that I've got a pretty impressive panel, and it will be a pleasure discussing this particular part, the maintenance management of advanced ovarian cancer. Okay, so we begin here. So as we all know that ovarian cancer is a disease which is highly chemosensitive, but unfortunately the relapse rate is pretty high, especially within 5 years. And if we talk about stage 3 and 4 disease, the relapse rate is as high as 75% in first year itself. So there's a lot that needs to be done. And so if you see the landscape of ovarian cancer management, so last about 40 years or so, till 2015, it has been all about platinum in various combinations. And in last 6 to 7 years, we have got multiple approvals, almost about 14 FDA approvals of newer agents, and mainly around PARP inhibitors and BEV. So we all have been part of various forums where these the trials based on which these drugs were approved have been discussed extensively. So today, rather than digging into details of these trials, I would like to utilize your expertise in having some insight around these data. So going ahead, the first thing that comes to my mind that has this data of last 5-6 years changed our practice. I would like to ask Dr. Devesh itself that presently how much your practice has changed in last 5-6 years in terms of ovarian cancer management.
So I think definitely in era of this targeted therapies as well as the germline. So within 2 or 3 years after the introduction of the BRCA testing upfrontly or in metastatic settings with BRCA, I think overall whole scenario have been changed. So publishing the data BRCA, if we are doing the BRCA in upfront settings, so there is data about if the BRCA is positive, so further trials dictating that the olaparib maintenance can be offered to after the completion of this chemotherapy if they are BRCA positive and high risk. Okay. So I think even in metastatic settings, if the BRCA comes to positive or irrespective of BRCA, so therapy segments have been changed, and even diagnostic part I have discussion so that we are doing no test of BRCA initially, and nowadays in ovarian cancer in my clinical practice overall 25 to 30% of patients I am offering the BRCA test upfrontly, even in germline as well as somatic. First germline and then somatic.
You know, the reason why I asked this is because if I tell about myself in last, say, couple of years, the number of patients in whom I've used, say, PARP inhibitors or BEV or in combination have not reached double figure, because though it's very encouraging, but somehow it's not very practical to use. But yes, data is quite encouraging. So I'll just in brief, I would say just visit the trial data on which these drugs were approved. So mainly we had 3 trials: Solo 1, Paola 1, and Prima, and they were more or less similar, except with some differences. Like in Solo 1, there are only BRCA mutated patients, where in other 2 is all comers. And the Prima, though niraparib is not available in our country, so we'd not be discussing, say, niraparib or Prima data, but just for record, the Prima used mostly high-risk patients, and the PARP inhibitors are used for 2 years in Solo and Paola 1, and it's around 3 years in niraparib. So in Prima, so more or less they are similar data. And based on this trial, olaparib got approval in first line in BRCA mutated patient as well as in HRD positive patients in maintenance, and in second line, irrespective of BRCA status, and third and fourth line beyond in patients who are BRCA mutated. Niraparib had something similar data, and rucaparib is approved only in maintenance therapy in recurrent ovarian cancer and treatment in subsequent lines. And of course, this was based on very impressive PFS. In Solo 1, the HR of around 0.30 and Prima 0.43, and Paola even impressive 0.33. And with manageable side effects like mainly myelosuppression and nausea, which led to reduction or interruption, but very few discontinuations. So overall, we see that very good, interesting data with manageable toxicity these drugs have, and that compel us to use. So I'll come to the case, which is as routine as it can be, like a 51-year-old lady with a good insurance cover. That means then the funds are not an issue. Stage 3 ovarian cancer, PS2, and with hypertension. So we all know what is going to be the management, which most of us will do. But still, I would like to ask one of my panelists, Dr. Jyoti, how do you go ahead with this particular patient? Dr. Jyoti, is she there?
I think Dr. Jyoti is not there. Dr.
No problem. Dr. Mohit, are you there?
Yes, sir.
Yeah, hi. So very standard case. I know it doesn't need any specific answer, but still, I would like to ask my panelist that what would you do in this case?
So I would like to discuss with my gynec onco surgeon that whether they can upfront operate this or not. If they feel that they can operate and can achieve the optimal cytoreduction, then I would like to offer surgery.
But if they, which many of the case which we see that they are not comfortable in, if the disease burden is high, if there are peritoneal nodules are there, or there is some suprahilar nodes are there. So many of times they send us back for the neoadjuvant chemotherapy. And then we do switch 3 cycle of paclitaxel followed by surgery followed by 3 more. That's how we routinely do. Now the additional point which I want to discuss is that now there is a emerging role of, if it is stage 3, then there is of course the role of bevacizumab as well. And of course we should offer the germline testing. We should discuss about that. And as you are telling that the patient is having good insurance cover, then we should, based on the testing of the genetic result, we should offer the PARP inhibitor for the maintenance.
Yeah, I would completely agree with you, especially the first point that in case patient is upfront operable and if R0 can be achieved. But otherwise, most of us would follow, as you rightly said, it will be NACT followed by CS and adjuvant chemo. As you said, that brings me to my next question, that how comfortable are we in using BEV in NACT or even in adjuvant setting, which is in and around surgery, either used before surgery or immediately after surgery? Because if you see the Paula data, minimum 3 cycles of platinum and BEV is necessary to put that patient in maintenance therapy with BEV and Paula. And as we know, that the Paula data is pretty impressive and compelling that we should use this combination. So how comfortable are we? Dr. Ankit, are you around?
Yes, sir. Yes, sir.
Yeah, hi. So tell me about your experience and view on using BEV in NACT or even adjuvant, immediate adjuvant setting in ovarian
So
cancer.
sir, personally, I don't use bevacizumab in neoadjuvant setting until unless if you are thinking of a R0, R1 or R2 resection, because whatever it was the data where the bevacizumab showed a no PFS benefit and OS benefit. Otherwise, if the patient is operable and patient is giving NACT just because of the poor performance status or a huge burden of the disease, I would like to go with the chemotherapy, not with the bevacizumab. But if there is any disease infiltration into the bowel or bladder, whether we are planning that after 3 cycle of chemotherapy as well, there will be a R1 resection or R2 resection, then I would like to add a bevacizumab.
Yeah, actually, very true, because BEV is a difficult drug to use. And whenever I have used, in fact, I have found proteinuria quite troubling in many of my patients. And this lady in particular, say, she is hypertensive also. There's going to be a challenge.
Yes.
And, around surgery, it becomes all the more difficult. But still, Paula says that we have to use it. But one thing, which I somehow could not find the answer, and I tried exploring it. If Dr. Devesh, you can just put some light on this, that why bevacizumab was made mandatory in this pre-maintenance setting, that why they insisted that BEV has to be used. If there's some explanation to it, that one thing which I heard in some forum, that since BEV is also one of the comparator arm in Paula of the 3 arm, that's why they insisted that BEV has to be used. But why before maintenance? I mean, if you can put some light on this.
I think there is no clear view, but just if there is the gross ascites and there is inoperable disease, so in few cases, I will use this bevacizumab in neoadjuvant settings and just give for 2 cycles and then stop for another. Will give
that I agree.
cycle.
Yeah. That I agree.
But I think I am not agree with this Paula trial. Is it bevacizumab plus the olaparib maintenance is required? So I am not convinced. So I will in my
later. But yeah, please go ahead.
I'm just convinced with this chemotherapy arm followed in by the surgery and adjuvant setting chemo, and then olaparib can be offered. But if we are using bevacizumab maintenance, so we can use upfrontly, but not in cases with the olaparib.
Okay. Any different view? Dr. Mukesh is there. Would you like to throw some light on it? Because there's something I'm just trying to explore, because I'm trying to find the right answer. So maybe I don't know the answer. Maybe that's why I need some input. That Dr. Mukesh, are you there?
Sir, Dr. Mukesh is not there, but Dr. Umesh is there, sir.
Dr. Umesh, okay, great. So Dr. Umesh, if you got my question, that would you like to throw some light on this?
So definitely in my personal practice, I usually don't use bevacizumab. I usually give chemotherapy only. And, do not use bevacizumab as as, as rightly said by Dr. Divesh that we should use chemotherapy, surgery, adjuvant chemotherapy, and we can give maintenance all of it.
So I take it that both you and Dr. Divesh, that you so far you have not adopted to Paula, right? So okay,
Yes.
good. Fine, agree. But I was just checking somewhere some theory says that when you use BEV, because of the hypoxia it creates, the GIS score increases. It improves the say the HRD, and probably that is a thought process behind that. But I'm not sure about it. But this is just a theory that BEV does causes hypoxia, increases GIS score. Maybe I mean this is just a extrapolation on my part, but maybe the right answer we need to ask them. Okay.
I want to discuss one point in this.
Yeah,
that
please.
Whether the genetic testing should play a role in this. Means if the patient is, I think, BRCA1 or 2 positive, then I think we need not offer bevacizumab because we have olaparib for the maintenance based on the SOLO1 trial. But if patient is germline BRCA1 and 2 negative, and then if we find HRD, then we might offer bev plus olaparib based on the Paula1. So I think if the patient is BRCA1 and 2 negative, then I think bevacizumab plays some role because we have something to offer to delay the progression.
Yeah, I agree with you, Dr. Mohit, and this point holds true at least in our practical, clinical practice, because trial data and theoretical data is separate, but on ground this is what we do. And one more thing with regarding HRD testing that we'll discuss subsequently soon. But regarding our previous question, the NACT BEV in NACT, there's not much data. One Antilia trial is there 90 odd patient and doesn't give much insight so that BEV should be used. So far BEV in NACT, at least I would not use, and I'm sure 90% of people don't use more than that. So coming to my next question, do we use maintenance therapy in ovarian cancer in first line setting, whom I have not visited? Dr. Sunil, are you there?
Yes, I'm
please.
there. So yes, maintenance therapy, I have recently started using the maintenance therapy. Also, as we are discussing the things, BRCA testing and maintenance PARP or bevacizumab maintenance, I am trying to use routinely.
Okay. So you are convinced with the idea of maintenance therapy, right?
Yes, yes.
Okay. I'm sure other panelists would also agree, because if we see the natural progression of ovarian cancer, the PFS keeps decreasing after every relapse. So it makes all the sense to use maintenance therapy in ovarian cancer. Though somehow what I have seen, or what my experience is, that still more than 50% people are not using maintenance therapy in ovarian cancer because of different reasons. And reasons are very valid once again. But yeah, it is something that we must consider, using maintenance therapy in ovarian cancer. So our dilemma is that I would just like to have just a poll. I would say that of all these 4 options, observation, PARP maintenance, BEV maintenance, and PARP plus BEV, just say what you would look, just answer, what would you like to do in, say, this kind of patient? Just your consensus, like Dr. Divesh, what would you do after these 4 options?
In this patient, just I will use this platinum combination chemotherapy. If BRCA comes to be positive, then followed by I will use the PARP maintenance. Otherwise, if there is financial concern, so I will just incline with this platinum combination chemotherapy followed by the observation.
Okay, so this patient has good distinct insurance coverage, but you are not a BEV type. Okay, I got it. Dr. Mohit?
Yes, sir. So what I agree with Dr. Divesh in the part that if the patient is BRCA1 or 2 positive, then I think platinum doublet followed by olaparib maintenance is sufficient. Nothing extra is required. But if patient is, the question rises that if the patient is BRCA1 and 2 negative, then I think if HRD is also negative, then BEV plus BEV maintenance looks okay. And if HRD is positive, BRCA negative, then I think the last option, that is platinum doublet plus BEV plus PAR plus BEV maintenance based on the trial result. Of course, you are right that in the clinical practice, because of various reasons, we are still unable to apply the 4th point. But I think the 2 and 3 point we are doing.
one thing which I personally I have seen that though it sounds very nice, data is also very good, but using PARP inhibitors at times indeed a challenge, because wherever I have used PARP inhibitor olaparib, very rarely I've been able to use 300 milligram BD. Most of the time I have used 150 BD, and I know many people who are using 150 BD. In fact, Dr. Amit Agarwal, I was talking to him, he has a good data of 150 BD, of olaparib, and patient doing pretty well. This is one part. And secondly, I want to know, have any of you seen, say, olaparib induced MDS or AML? Though theoretically it's possible, it does mention, but
Dr. Sunil here, sir. So I have seen olaparib induced MDS 2 cases.
Oh, really?
One was a prostate cancer and one was a young TNBC.
Okay.
They were treated with olaparib and presented with long-lasting pancytopenia, and on bone marrow it was a MDS.
Yeah. So if you've seen
So
two,
it is over the period of last 4 or 5 years. No,
no, but
not.
I would say it's still significant, because say it mentions just about barely say 1 to 2%, but and if you're seeing two cases, I think it's pretty sizable. So anyway, the consensus says that if affordability is not an issue and patient is BRCA mutated or HRD positive, say using PARP plus BEV maintenance is a good choice in case BEV has been used prior to maintenance. Otherwise, PARP maintenance is again a second best option, I would say. Great. Now, just as we discussed earlier, chemo has lost its role in maintenance therapy, because many of our teachers, they have been using paclitaxel in maintenance of ovarian cancer. But over a period of time, this meta-analysis says that there's a lot of toxicity and not much of benefit. So it's gone out of favor, and definitely with the present data, yes, indeed. And regarding BEV, we have two iconic trials, like ICON 7 and GOG 218. And both these trials tell us that using BEV has a PFS benefit, but no OS benefit. This all of us know. And it does give a reason to use BEV in ideal setting. So yeah, BEV does have a role. Chemotherapy definitely no. So around the same thing that we have been using, as I said, that we all know the trial data and we all have been listening and treating patients. But if I have to select the ideal patient, whom you have to say place on PARP inhibitors, how would you choose? Like in practical sense, Dr. Mohit, ideal patient for you, where suppose cost is not an issue and you have to use PARP inhibitors.
I think stage 3 or 4 CA ovary with BRCA mutated and first line maintenance. That's what I feel.
Okay. Dr. Devesh?
I agree with Dr. Mohit, but just want to add young and fit patients. I think younger the age, I am not offering the 270 or 80 years for maintenance. So I will just offer for younger patients, 40, 50 or 60, well fit patients and affordable, as well as BRCA mutated and stage 3C and 4. Definitely I will offer.
Okay, so as you also follow age criteria, like if the patient is younger, you tend to use maybe PARP inhibitors more comfortably. Okay. Any other view, Dr. Sunil, Dr. Ankit?
Yes, sir, definitely. I agree with Devesh, sir, because even if the patient is younger only, then only or if it has a PS1 or PS2, then only I would like to.
This I find interesting. This younger patient, what is the rationale behind this? I would take this point, but what is the rationale behind this?
Yeah, younger or with a good PS.
Good PS is fine, yeah, because I know a lot of asthenia and say.
So for ovary, I think 60 is young.
Okay. So, Dr. Dinesh,
I think there is not for 80 or 70 years. I think
yes,
little bit fit 50
Yeah,
to
so,
60, 50 to 60, 50 to 62. There is fitter, younger in the sense of fit patients.
So I'll take your point, because it is a very valid point, because the life expectancy makes all sense. There's no point making an 80-year-old patient spend over 20 lakhs, 30 lakhs, on the PARP inhibitor compared to using in relatively younger patients. So that way, yes, very good point, very valid point. Fine, Dr. Ankit, do you have any a different view apart from this, or if you go ahead?
No, I agree with this.
Great. Let's move ahead. Now, I mean, this is a very, this question again, I find it very interesting. And something which I find very, when I get really confused, I start finding it interesting. So, I want to ask that, as most of you said that you would like to get BRCA testing for all your patients nowadays. Fair point. And when do you get HRD testing done? Dr. Ankit, which is the ideal time as per you to get the HRD testing done?
So upfront, sir, because now because I was actually ordering it on 4th or 5th cycle. Now I have problem with managing the patient because patient has already received 3 cycle of chemotherapy, then I intervene cytoreduction, then the patient is HRD positive but BRCA negative, and I haven't given a bevacizumab to that patient. So how can I start on the patient on the olaparib with bevacizumab? So nowadays I've started doing on first cycle as well, or if it is a upfront cytoreduction, then with the first cycle.
Okay, so any other rationale apart from you are doing upfront? I take this point. We should do upfront, but apart from the reason that you gave, any other reason that you can think, Dr. Mohit? I mean, you feel that you should do it upfront, but anything else which is equally important, reason why doing it upfront?
I think, of course, it should be done upfront, but in stage 3 and 4 ovarian cancer, if we are using bevacizumab as a part of induction, then I think HRD makes sense. Because niraparib works irrespective of HRD. So if we are talking about the web-free regimen and we are not using with niraparib, that's different point. Okay. So I think if the web is the part of induction therapy, then we should discuss HRD because Paula-1 will play only there.
Yeah. So, but I'll again go back to Dr. Ankit. So when you get HRD testing done, so which platform you use? Then how do you get HRD testing? Which is the say the lab or the platform that you use? I'm not this lab, but this is reasonable.
And then there has been a lot of discussion about that. Sir, first it was a BRCA1, BRCA2, then whether should we do HRR or HRD?
Not that. Let me put my question different way. For HRD, how do you get it done? Which lab you?
Nowadays I'm getting a MedGenome or strands, and the core is using HRD along with HRR also. But then there is no data, sir.
Okay. So, since we have less time, so I would like to straight away give you my views on this. And please feel welcome to, correct me. So one reason why we should do upfront HRD is that it is SNP array data has shown that once you use chemotherapy, the GIS score comes down. So if you say do HRD after doing chemotherapy, it's possible that you may get BRCA mutation positive, which will remain positive, but you may get HRD negative status, right? Or GIS score may be less than 42. So that you will take it as negative. So that is one reason. Second reason is that, for HRD, the only globally 2 tests have been approved. One is Myriad, My Choice, which is not available in India, and which is a kind of, say, companion diagnostic test for olaparib and niraparib. And other one is this foundation one, which is for rucaparib. Now, the problem is that Myriad is not available to us, and foundation one is a companion diagnostic test for rucaparib. So that ideally you cannot apply that data for olaparib. And secondly, the cutoff score that used by foundation one is 33, right?
Yes.
So now the alternative solution, which is being offered by 2 labs in our country, one is Strand and second MedGenome, to the best of my knowledge. Why these 2 labs I'm saying? Because they are validated apparently, and it has been discussed in ESMO also sometimes.
Yes.
So these 2 labs, in place of GIS score, they use GSS score, and they say that in place of LOH and LST and TAI, they are using this GSS score, which is basically site, copy number, and length of the copy number of this, and they give a scaring score. And though it is relatively validated, cost is less. I think some companies doing it free of cost also. But and there the cutoff score is 50. So there's a lot of confusion that which lab to use, how to lab. But in our case, we have no option but to go for these labs. But these labs, suppose say AstraZeneca, for example, they are giving it free of cost, as a promotional offer or whatever. Their condition is that they'll accept it only it is upfront, and the reason for upfront is the same which I mentioned. What they say that the GIS score comes down, and which is to some extent correct also theoretically. So in my opinion, if at all we consider HRD, we should try to get it done if possible upfront. In case nowadays we are moving towards using BEV and PARP inhibitors in maintenance, So we should be a bit more proactive and get HRD done along with BRCA in the beginning only rather than after giving chemotherapy. So, I mean, any view of the panel on this? I would just like to, ask.
Yes, sir. Yes, sir. Actually, we do on the first biopsy only, but that the inertia is there at all across all the doctors in our.
Okay. The purpose of this panel discussion is that whatever understanding I have, I'm just trying to impart. So if it might help, just changing our strategy a little bit.
It is very difficult to convince the patient only on the first biopsy. Yes, sir.
But so far, this test is free of cost. Let me tell you, if you contact AstraZeneca through some genome, they're getting done free of cost. Yes. So one good thing, So we can consider, right? So that this part we have already discussed. So this is regarding HRD. Why, like Dr. Mohit said, that we should get BRCA done, and then suppose BRCA negative, then we should go for HRD. I think it's a good idea. But with this thing in mind, maybe we can consider upfront, and also because 50% of ovarian cancer patients are BRCA positive. It has been seen in the scholar data also. And out of that, around 20% people are BRCA mutation positive. So a sizable number of patients are positive. So we can consider using HRD upfront, that might help, because out of that 50, even 20% patients are BRCA mutation positive. And suppose, simultaneously we order germline BRCA, which is not very expensive. So maybe that will serve our purpose. Now, why it is important to get HRD done also? Important is because, when we look at the PFS data of, Paula-1 in HRD unknown patient, it shows PFS benefit. But when we explore it further and we see that this benefit is seen only in BRCA mutation positive or HRD positive and not in negative patient, which is the significance is lost. So it is very important to prove HRD and then, go ahead, because that gives us a solid reason to convince the patient and go ahead and start the patient on maintenance therapy. Now, last just couple of 2-3 slides. So, but one thing, this question is asked to me by most of my patients whenever I've used, why using olaparib? Why using olaparib? Especially, ovarian cancer patient is in CR, everything is fine. Then using maintenance therapy, giving toxicity, financial toxicity, So this question always comes. So answer to this question is that if we see the SOLO-1 data, the 5-year survival data, the PFS data, it is so impressive. And this ESMO last week, they have shown the OS data also, which shows a meaningful benefit even at 7 years, SOLO-1. So it is very encouraging. And Paula, similarly, again, this ESMO only, it shows OS was prolonged. So yes, it makes all the sense to use olaparib plus minus bev if possible in the suitable patient, to, if possible, to use these drugs. I am pretty convinced. I'm sure most of you are. So this one question I would like to ask all of you, that of all these 4 factors like BRCA and HRD status, risk group, stage, and use of BEV, so which are these patients who benefit maximum for PARP inhibitors? I could pull out some data. That's why I'm asking this question. So just your view, that out of which is most important as per you, Dr. Devesh, what you feel? Out of these 4, just one if I have to choose, you have to choose which
only
one.
Only one.
All of them are important, no doubts. But most important, which one?
I think BRCA or HRD status, I think, most important.
Okay. That is kind of essential, I would say. But in terms of importance, Dr. Mohit, any other view? I would agree with Dr. Devesh. I don't deny it. But
I think if we are considering other PARP inhibitor as well, other than olaparib, then I think stage is more important, because we will not use in stage 1 and 2.
Okay. Dr. Sunil, your answer, out of these 4, which is most important?
I think Dr. Sunil is not there.
Okay, Dr. Ankit?
Sir, BRCA followed by HRD, followed by stage, followed by high risk.
Okay, great. You'll find it very interesting because, if we see one by one, it shows that, I can't see, anyway, it's something like the BRCA and HRD positivity are very, very important. It is seen irrespective of risk group, whether patient is low risk and high risk. Point number 1 taken, which Dr. Devesh mentioned, agreed. HRD positive patient, use of BEV, again, it helps. So there's also another point, agreed. In patient who are HRD positive, BEV plus OLA compared to BEV, again, BEV plus OLA is fine. So this is also agreed. And irrespective of BRCA1 and BRCA2, their benefits of BRCA is also very important, agreed. But now I'll pull out this data. This is a kind of cross trial, say, comparison, you can say. So scientifically very significant, I can't say. But if I'll just draw your attention towards this. In Paula and Solo, the two group of patient we divide: patient who are higher risk, like patient who had R0 surgery and patient who did not have R0 surgery. Now, R0 surgery patient who did not have R0 surgery, at 1 year in BEV plus OLA, the PFS was around 90%, and in year 2, it came down to around 60%. So after 15 months, there was a dip in say BEV, PFS in patients who used BEV, despite of BEV being used, and at 2 years it became 0. And in Solo 1 also, there was no difference. At 2 years, Solo 1 PFS was also same. So BEV here, you can see that BEV was used, but BEV did not make a difference in patient where R0 surgery was not done. But interestingly, where R0 surgery was done, at 2 years, the PFS in OLA plus BEV was 96% and above 80% even in Solo 1, where BEV was not used. So there's something more than BEV. Though, like OLA 1, it was 96%, in Solo it was 80%, so BEV definitely helped. But what helped maximum was R0 reduction. So if you ask me, the most important patient would be starting top to what R0. If I have to choose one patient, that okay, who's the ideal patient? In my opinion, I would say patient who had a R0 surgery, who's BRCA mutation positive or HRD positive, along with BEV and good PS, as you rightly said, and the younger age and all those things, I'll take it. And that is a patient. So in one way, we think that patient who's at lower risk, we could achieve R0 surgery. Why using that? But actually, they are the patient who will benefit maximum. If you could achieve R0 surgery, HRD positive or BRCA positive, use OLA plus BEV in these patients. In case if you used BEV before, you will get the maximum benefit. PFS more than 96% in 2 years, and now we have the Paula data also, OS data at 7 years, which is pretty impressive. This ESMO presented. So in my opinion, they are the best patient. That's what I can think of. So that answer. So this is the first group patient which we discussed earlier. They are the best patient to get, and that's how probably we can convince our patient. One last thing regarding the use of BEV, 15 versus 30 cycles. So it has been proven that 15 is adequate. We don't need to use 30. And another thing, last 2-3 slides, Dr. Devesh, I know time's up. So maintenance therapy in recurrent ovarian cancer. We all are probably pretty convinced that we should be using it. Any different views like in maintenance compared to first line or second line? Earlier it was like use in second line, why using first line? But now second line, would you prefer to use with this first line data?
I think definitely, and I inclined for the maintenance if there is in second line also.
So if the patient,
you have responded very well. So can put on the maintenance, the olaparib or rucaparib in second line maintenance therapy.
Yeah, so suppose the patient has not received in first line, definitely it makes all the case. And Solo 2 is gives us the answer with the PFS, good PFS benefit. So we should definitely consider in BRCA, say in second line, especially when we know that you don't have to have BRCA positive or HRD positive to use in second line recurrent setting. So there's one good option. Now there's some data about PARP rechallenge. I'm sure none of us have done it. I have done it in one patient, and I'll be honest, I had some success. I rechallenged with PARP inhibitors because that time I was in army and cost was not an issue. It was available to us, so I could be a bit extravagant and I could use it. But let me tell you, the data says this trial data, Oreo trial data says that there's a PFS benefit irrespective of BRCA positivity, prior use of chemo or BEV or no. But apart from this data, personally also one patient I have used and it is beneficial. So you can consider PARP rechallenge also in case you are a suitable patient. Okay, so finally, so the standard of care.
Just want to ask: is that time when we are re-challenging this PARP inhibitor, so patient performance is fit at that time or not?
Yes, definitely. That is definitely a point, because if the patient is not in a good condition, you can't think. And rather, you try doing these experimental things only when you feel that patient PS is good and patient can take the treatment. Then only you try to go a bit extra mile and try to do all these things. So I had the success. Of course, it was limited only. So this something what we have discussed, that in case if we have used BEV earlier, then in that case, if HRD is positive, then we use Paula, otherwise use BEV maintenance only. In case BEV has not been used, because then maybe in case who are HRD positive patient, we can use Olaparib. And ESCO also supports this thing, and ESCO recommends that we should use PARP inhibitors in maintenance as a recurrent setting as well as in treatment. So all data to support, everything is there. Just intent is required, you can use it. Regarding role of immunotherapy, I know that you all agree and you all know that there's not much of role of immunotherapy in ovarian cancer except patient who are MSI high and you post against the wall. But I just want to know, Dr. Mohit, have you used immunotherapy in any of your patients in ovarian cancer so far? My answer is not.
No.
Even in patients who are MSI high?
But I yet to find.
Okay. But Dr. Sunil, you have been lucky to see rare cases. So okay, he's gone. He's not there. Okay, Dr. Devesh.
No MSI. I have not done, but I think no experience.
But you know that this, in case suppose we are posted against the wall, and as you said, that patient is in good PS, and patient say, no, doctor, I want some treatment. Then get MSI done, MSI, use immunotherapy, and that thing that you can do. But otherwise, the trial. Yeah, please go ahead. Yeah.
Experimental form can be challenged if there is MSI high, and there is no other response to previous chemotherapy.
Yes, that's how we use in most of the cancers. So this immunotherapy data, no benefit. So far immunotherapy is not recommended within cancer, and that brings to the end of my the panel. So thank you very much. It was a pleasure interacting with all of you. I exceeded by about 3-4 minutes. So apologies for that.
Yeah. So thank you, sir, for very well discussed, and I think I am more knowledgeable after this discussion. So role of this PARP inhibitors as well as maintenance and HRD. So I think you have very well discussed about this, and thanks to all panelists for sparing your time. And thank you, sir, for sparing your time in your busy schedule. And thank you, sir. So,
always a pleasure.
Yeah, so I will conclude the day sessions or on day 2 of this oncology updates beyond 2022. So we have very well discussed in first part the GI malignancy, so metastatic CRC sequences, as well as the first line treatment in gastric as well as advanced gastroesophageal cancer metastatic settings. So very well discussed. That sessions was sponsored by the BMS, followed by the further role of cabazitaxel in prostate cancer, and very well discussed this prostate cancer panel discussion in castrate resistant prostate cancer by the Dr. Lalit Mohan, followed by the RCC treatment sequencing and urothelial cancer sequencing by the Dr. Rakesh as well as Dr. Preeti, and the next sessions by the Dr. Manish for the further the panel discussion in this advanced ovarian cancer. So thanks all my seniors as well as my colleague as well as my faculty as well as my friends for attending and sparing your times for 2 days this scientific events. And without the scientific partners Roche as well as Glenmark, Entas, Fresenius, Biocon, Zydus, Cipla, Lupin as well as Merck, this session at this conference is not possible. And I will I just thanks to all scientific partners for this conference. And just last for this thanks to Horizon members, event partners, Surbi, Ankit, as well as support team from this Tarun Mathur. Thank you, and further good night. Thank you.
Thank you so much, sir, for your kind words, sir.
Yeah, thank you.
Good night, sir. Good night, everyone.
Good night all.